Good morning. You're muted. Can't hear you, Doreen. You're muted. Good morning, Wendy.
Good morning. How are you, Rabbi?
I am good. How are you?
Am I unmuted now?
Nope. Can hear you perfectly.
Oh,
Yeah.
how are
Morning,
you?
Doreen. I'm okay. Doing okay. What a lovely mug, Wendy.
Oh, this one. Yeah.
Beautiful.
Oh, that's pretty.
Yeah. I get them at in Dundas at the yearly sales. All the potters come together at the armories, I think.
Yep. Very nice.
That's mine.
Also beautiful.
No competition here.
Okay.
No. Where's yours, Rabbi?
Morning. I'm just drinking water this morning.
Oh, that's clear.
Morning, Shirley. You are muted. Can't hear you, Shirley. I cannot wait till the day arrives when we no longer.
Okay, I'm not muted. You could hear me?
Hear you fine now, Shirley. Good morning.
Good morning, everyone.
Morning, Shirley.
How are you, dear?
Hanging in.
Aren't we all?
Baruch Hashem. Indeed.
Yeah.
Listen, that's good.
So my exciting news is I'm going this afternoon to get my shot.
Oh, okay.
Is this your first one?
First one,
Oh,
Where are you going for it?
West 5th.
Okay.
And which one?
Pfizer, I believe.
Oh, good
Yeah.
for you.
They're
I got 2 Pfizer a little while
distributing
ago.
there. You know,
Good
I
for
have a lot of colleagues in the States, clergy, and they got their second shot in February.
wow.
Oh, my son's in Colorado. They're all shot up there.
Yeah, my son got his second shot 3 weeks after his first one just a couple days ago.
Oh, yeah.
Although he did say the second shot completely wiped him out. The first one he barely noticed. Second one he was out of it for 2 days.
No way.
When I had the Pfizer, the second one bothered me a little, not too extreme, but I felt a little out of sorts.
Yeah, that's normal. Good morning, Gloria.
Hi, Miss Gloria. How are you, darling? Nice to be seen. How was Bailey, Rabbi?
Bailey is spectacular.
Okay.
She's doubled in size in the, what is it, 4?
Oh, yeah, the little
4
ones
weeks
grow
ago.
very big.
She's a very sweet dog. We did well.
Oh, Bailey's a dog. I was going to say, do you have another grandchild?
No. Abby's the grandchild.
Yeah.
Bailey's the puppy. Right now, the puppy's getting most of the attention.
Okay.
Rightly so.
She looked pretty cute.
She was very cute.
Passover, I guess it was, or maybe before Passover. I forget which service they joined.
He's gorgeous.
Yeah.
And she and Paula have bonded like this. She's already second Paula gets up and walks away. She just trots along right behind her.
Oh.
Morning, Richardsons. Good to see you.
Does that mean Paula's feeding the dog? Rabbi, if you want the dog to follow you, you gotta feed her.
I know, that's the thing. Paula walks around with a pocket full of kibble and stuff. I'm like the mellow one, she just wants to crash and lie there. She comes to me and we, hang out together. But if she's all full of beans and wants to run around and stuff, she knows mommy's the one to play with.
Do you read her Bible stories?
Of course. Talking donkeys, all kinds of stuff.
It's like having a baby in the house.
It is.
They never grow up.
She's going through the night pretty well, although
Good.
very often I took her out at 6:30 this morning.
They never get out of diapers, though, the dogs. You have to go pick up their poop for the rest of their lives.
Well,
That's right.
Pick it up in the yard. And she's doing really well on a leash. She likes to go out and meet other
Okay.
people and meet other dogs and stuff. So, yeah, so far, working out perfect. I worry though about what's going to happen when we start going back into the temple full time.
Have to take her with you.
I think that's what Paula's plan is. Make sure she's office trained.
That would be nice.
Add a little cuteness to the temple.
Uh-huh.
We have 5 minutes. I'm hoping our presenter will join us. Quite the rainy spring day today.
Don?
Rabbi, may I ask you a quick question?
Yes, Annette.
Yes, my dear cousin David Maxa, who you met at the conference, and I are having a Zoom meeting tomorrow. And I wondered if I could bring your greetings to him.
Sure.
Yeah.
Uh,
He's-
David Morgan, you mean?
No, I don't mean
Oh,
David
sorry.
Magan, I mean David Maxa.
Maxa. Okay, I
The
wasn't sure if I heard.
young new rabbi who
Yes.
is just doing his second year in the rabbinical order, and he's
Good for
now
him.
got 2 synagogues that he's working with, and because there aren't that many of them in Czechoslovakia yet.
Right.
so-
Okay, of course. That's
Got it.
now I
yeah.
know exactly who.
And that's, and we discovered only in the last few years that his great grandfather and my great grandfather were brothers.
Wow.
So, yes,
Wow.
yes.
Because
So-
I had a lovely, nice long chat with David Morgan this past week.
Oh, yes, he's so
He's such a nice guy.
menschy, that man.
Yeah.
Yes.
He was telling me in their travel agency, which is the agency we use for all the temple trips, which is how I met him.
Uh-huh.
Before the pandemic, they had 75 people on staff. Now they're
Yeah.
down to 3.
Yeah. Yeah.
And that
But
doesn't include the tour guides who work on their
No.
freelancers.
No.
Shocking. But he is saying everything is starting to wind up again. And if we want to do another trip in the next year, we need to sort of book now, because while nobody's traveling right now, everybody's anticipating a year from now it'll be good. So they're
Yes.
booking hotels and stuff like
Yes.
that now.
Yes. Yes.
I don't think so.
Don't think so?
I don't think so. Not a year, not the rate we're going, not
Yeah.
the rate we're being vaccinated.
Oh,
Oh,
good.
Apparently Israel is quite back to normal. I was talking to my cousin,
Yeah.
her daughter's back in school. They're going out to restaurants again and everything.
Mhm.
You know,
Mhm.
everybody's got 2 shots in their arm, and
They got it ahead of time. Yes, they had enough for everyone. We
They
don't.
bought it. They
Yeah.
bought it early. They paid full price. They bought it early.
That's right.
politically they're a mess, but medically they're actually doing well.
Oh, thank God. At least people will live.
Yeah, exactly.
Wow.
I just know that as soon as I can travel, first place I'm going is to see my granddaughter in Arizona, and the second place will probably be Israel.
I'm going to Colorado as soon as I could book.
Yeah.
Going to Toronto.
I haven't been there since
Or even
14,
Toronto.
15 months.
The fall. I've been in the
Yeah.
last fall.
I
Yeah.
go to my parents regularly, but I haven't seen them since February of 2020.
They're in Toronto.
I'm going to have dinner or lunch on the deck with my daughter and her and her friends who have become my friends
Very good.
when it
Well,
is when it's
Israel.
safe to go.
2022 in July. Oh,
Yeah.
Hi, Sheila.
Yeah, we have lots of participants, but our speaker's not here yet.
okay.
Mr. President, good morning.
Mr. President, good morning.
Mark Levine.
He's muted.
Good morning, Erwin and Diane. Good to see you.
Good morning to you.
Oh, here she is. Perfect.
Hi, Diane.
Hi, Gloria. You remember me now?
No, you still don't look like somebody I know.
You have to see
Samantha,
me.
good morning. Thank you for being with us.
She's muted.
She is muted.
Yeah.
Good morning.
Good morning. We're going to get started in just 1 minute. I'm going to do a couple quick announcements and an introduction, and then it's all yours. So thank you so much for being with us.
My pleasure.
You know what? Let's get started now. It is 11 o'clock. So good morning, everybody. Welcome. I am very thrilled that you've joined us for this new series of Breakfast Club, the first of which is today. And we have an outstanding guest with us this morning. We're going to continue over the next 3 weeks. There's going to be 4 sessions in entirety. Next Sunday morning, our very own cantor Paula Baruch is going to present, but she is not doing, for a change, a musical presentation. In fact, she is going to talk about her calling to become a Jew and a little bit about her own spiritual journey to Judaism and then to the cantorate. So that will be her presentation. The week after that, we have Gustavo Rimberg, the CEO of our Hamilton Jewish Federation, who's also going to talk personally about his life in the Jewish community in Argentina, in Buenos Aires, which is where he's from. And I'm really looking forward to that. And then our final session in 4 weeks, we have a soferet, a female sofer, a woman who practices the traditional Jewish scribal arts, writing Torah scrolls and mezuzahs and tefillin. It is not unheard of for women to be involved in that, but it is rare. And she has a wonderful story to share with us as well. So I think this is going to be a little bit different series this time, where we're going to be getting a number of different sort of very personal presentations. And that's what's coming up. I also want to remind everybody just quickly that this afternoon at 2 p.m., we have this special Yom Ha'atzmaut concert, which Temple Anshe Shalom is a partner with in presenting to the world. It's going to be a wonderful event. And there's also going to be a little bit of fuss in there as well. So be sure to tune in for that. And if you don't have the login information, I believe it's on the website, but if not, you can just email me or the cantor and we'll get you in at 2 p.m. So that's about it. So it is indeed my pleasure this morning to introduce. It's early this morning. Hang on, I'm just going to, oh, there we go. Our guest this morning, Dr. Samantha Winemaker. Her and her husband and 2 lovely daughters are dear members of our community, of our congregation. And Sam is an associate clinical professor in the Department of Family Medicine in the Division of Palliative Care at McMaster University. She teaches palliative care to healthcare professionals. She has won the Ontario College of Family Physicians Award of Excellence in 2010. And she also earned the Elizabeth J. Latimer Prize in Palliative Care in 2018 and the Dr. S. Lawrence Liebrecht Award for Palliative Medicine in the community in 2019. And Dr. Winemaker is getting a lot of attention right now for this wonderful new podcast that she and her partner have introduced, called The Waiting Room Revolution. So I am very excited to welcome to Breakfast Club this morning, Dr. Samantha Winemaker. Good morning, Sam.
Good morning. Good to see you.
See you.
Shalom to everyone. Rabbi, I was wondering if you could tell me, how long does the Breakfast Club go for?
Oh, I would suggest that you present for about 40 or 45 minutes and then save some room for questions and answers. And we usually wrap up around 12 noon.
Okay. Oh, wonderful.
That good?
Yeah, that sounds great. So thank you for inviting me today. As the rabbi said, I am a palliative care physician. I've been working full-time as a palliative care physician for about 16 years. And the special part about my practice is that I work in people's homes. So I help care for people who are facing any kind of progressive life-limiting illness and who are at home. And so I would say that, you know, to kick off, I would say it's probably important for us to know that if you look at the statistics, only 10% of the population will pass away suddenly from something. So that being, you know, an accident or trauma or, you know, an unfortunate suicide. So that represents 10%. That means 90% of people are going to pass away from something else. And usually it's some kind of illness that has a progressive nature to it and is life-limiting. So we're all going to die from something, you know, whether that's advanced heart disease or lung disease or liver disease or kidney disease, you can name any organ, or neurologic disease, dementia, ALS, or just frailty, just being old. These are not sudden deaths. These are deaths that happen after years of facing a particular illness. So some of these illnesses carry with them an average life expectancy of, you know, 2 years or 3 years or 5 years, or some of them have 10 years or 15 years or 20 years prognosis. But all of them will eventually shorten one's life. So that's the bad news. The bad news is we're all going to die, and most of us will not die suddenly. We're going to die from something, some kind of illness. Okay, so what's the good news? The good news is that, like I said, most illnesses have an average life expectancy that's related to them. And knowing a little bit more about an illness when you get diagnosed with one affords you time to be woke and in the know and eyes wide open when you're diagnosed with an illness. And that's not something we teach people or offer people typically. More commonly, when people are diagnosed with a particular illness, they give blind trust in the medical system, and they float through their illness as if their illness is never going to change. And as if that illness is going to stay steady from year to year, and we treat it like it's just a chronic illness. And what happens is you get stuck making decisions along that illness journey, not really knowing the full extent of what the behavior of that illness is going to look like over time. And so we're making decisions about life and about treatments at moments in an illness without the big picture of what the illness looks like, because rarely are we offered that roadmap. So when someone's diagnosed with something like Parkinson's or MS or COPD, which is a lung disease, or congestive heart failure, usually these illnesses are so busy and we're trying to fine-tune things in the moment that we don't step back and ask people, like our doctors and nurses, can you please tell me what this illness looks like? Can you tell me what it looks like in the short term, the midterm, and the long term? You've cared for so many people with this illness before. Can you offer me a roadmap? You may not want to know what the timeline is, but you may want to know what the twists and turns of that illness is going to look like so that you are best prepared to make decisions in the moment with the big picture in mind. So I just mention all of that because I'm going to be honest with you. Most times I meet people at the very end of their illness journey. It's very typical that I get referred to as a palliative care doctor at the 11th hour, when people are very advanced and they're at home, many of my patients homebound. And what I have heard over the years is the same thing over and over and over and over again, which is, why didn't anyone tell me sooner? I've met way too many people at the end of an illness who look back and say, I wish I had known more about how this illness was going to behave. I wish I knew more how things were going to unfold. Couldn't someone have told me that X, Y, and Z was going to happen? And the most shocking part is that often when I'm in people's homes and I can clearly see that they're at a very advanced stage of an illness, the person themselves doesn't even realize it. They know something's not going right. They hope to get stronger and better. They can't understand why they have very little appetite, and the families are very worried that they're not eating so much. And of course, from my perspective, I know this is all normal at the very end of an illness journey. But if people don't know that that's what to expect, that's a very scary place to be. And most of my patients and families are very anxious and very scared and very worried and have very little understanding about where they're at in their illness journey. That can amplify people's symptoms too. So I get called in as a palliative care doctor for, a pain problem or a sleeping problem or nausea. And I can't tell you how many times the symptoms are really not so much physical, but it's people's way of saying there's something not right here, because they don't know what they're experiencing is normal. And when I help them untangle that and ask them, are you the kind of person who wants to know more about your illness? And 99% of people say to me, yes. And I think to myself, why hasn't anyone else offered them this? But most people say yes. And I say then, is it okay I speak openly? Do you like information straight up? Or do you want information sugar-coated? And most people say, of course we want the information. Of course we want it straight up. Why wouldn't we want you have information? And then I offer them sort of a tour of their illness, a tour of where they've come from since their diagnosis. And I help them connect the dots. And we figure out where they're at that particular time in their illness. And then I ask them, are you the kind of person whose mind wanders into the future and wonders what's going to happen? And most people say, yes, that's what I think about at night. And that's why I'm not sleeping. And then we talk about that. Do you want to know about the future? Of course we want to know about the future. So this happened over and over and over and over and over and over again, times 16 years, full time, every day in people's houses. And I thought to myself, something's not right. I shouldn't meet people at the very end of their illness just by chance and have to untangle things for people and families when there's so many other people that'll be out there that will never have a chance to sit with someone and have a big picture understanding of their illness. And furthermore, it's too late to have to untangle this when people have already made major decisions along their illness journey. And so I started collecting all the stories of all the patients and all the families. And I worked with a very excellent partner of mine, Dr. Sien Xiao. He's a researcher in Hamilton at McMaster. And we took all that we were hearing at the end of life and we deconstructed it, pulled it apart. We reverse engineered it and we found new language and we positioned 7 key features of what we were hearing at the end and made them more acceptable and more palatable and less scary. And we turned them into 7 themes that we tested out and have come to realize that if patients and families were offered information about how to be a new patient and family from the time they were diagnosed, when they meet up with the healthcare system, they're likely going to get what they need from the time of diagnosis through the years of the beginning, the middle, and the end, and the advanced and the terminal stage of their illness. They will be able to tease it out of the healthcare system, who's often hesitant to offer this information. The reason for the hesitancy is not malintended. Doctors and nurses are very busy. They're working hard. When you usually present to doctors and nurses, there's something to figure out that day. Whether it's your blood work results or the CAT scan result, or you're dealing with a pneumonia or a urine infection or breathlessness, there's usually something in the trees that needs to be sorted out. And there's little time for the discussions about the forest. But it's the discussions about the forest of the illness that help people stay grounded, in control, in the know, and woke to their illness journey. Doctors and nurses also worry that they're going to cause sadness, depression, hopelessness, if they offer information that isn't in the package of, oh, you're gonna get better, or, oh, you look good today, Joe, you're my poster child for someone with heart failure. Oh, you look way better than when you were in the ICU. And well-intended doctors and nurses become amazing cheerleaders. And patients and families wanna be good patients and families. They trust their doctor's gonna tell them what they need to know when they need to know it. And the doctors are cheerleading, and they're waiting for the patient and the family to invite them with questions. But what happens is each one is waiting, and I'm generalizing, by the way, each group is waiting for the other's invitation. And what happens in between is a code of silence. And then I meet people at the end, and we scramble, and symptoms are amplified. And many people request assisted dying. So it's a really, really important issue. And I became increasingly alarmed about it and said, you know what? It's not fair. Everyone needs to know, the citizens of the world need to know that they're not the first person that's gone through whatever illness they have. Millions and millions of people. There's so much you can know to prepare yourself in an illness so that you get what you need. And so this podcast series that we put together is that we packaged everything up and we repositioned it upstream. And this is no longer about death and dying. And that's the best news. The intel came from death and dying, but it's been repurposed and repackaged in a way that we honestly feel that this information is good for anyone, even if you don't have a progressive illness, even if you're facing the healthcare system with just a plain old pneumonia, or you have a curative illness. This way of being as a patient and family is more protective in our current care environment. I'm going to stop there for a second. Can people hear me? Or have I been on mute the whole time? Oh, people can hear me. Okay. Do you want me to pause for a minute, or do you want me to share the podcast?
If anybody has questions, by the way, sorry to interrupt, you can put your questions into the chat box, and that way Sam can see them and share them. Sam, did you want to share, were you going to play some of the podcasts, or did you want to share your screen for anything? Or
yeah, I'm going to share my screen.
make you co-host. Okay, you should be able to share your screen now.
Okay. All right, let me just get this up. All right, so this is, so we have a web, so this is Dr. Cien Ciao. He is a researcher who's done lots of research in the same patient populations that I have. And we've partnered together because both of us about 4 years ago felt frustrated. Frustrated because we were spending so much time trying to scream at the top of our lungs about educating doctors and nurses, about having honest, open, reality-based discussions with patients and families about the big picture of the illness. And there has been some change for sure. And by the way, there are some doctors and nurses that are amazing at these skills, but there are a lot that aren't. So the two of us actually had coffee one day and said, you know what? Let's cut out the middleman for a bit and let's go right to the customer. And this is how we came up with the podcast series. Okay, so and this is what our website looks like. If you ever, it changes a little bit, but if you ever want to go on it, it's called the Waiting Room Revolution. And there's lots of other stuff there in addition to our podcast, but right here where you see listen to the podcast here, that's where you can have access to the first season. And there's 10 episodes, each of them between about 20 and 30 minutes. Okay. Don't get dizzy. I'm just going to fast forward here. Okay. So walking two roads, zoom out, know your style, customize your order, expect the ripple effects, tag your it, invite yourself. These are the 7 different episodes. Each of them unlocks a key. We used to call it a secret, a secret to moving from being in the dark to in the know. In the first episode, Walking Two Roads, this episode, and by the way, in every episode, we interview someone who is either in a position to have tried this out, or a patient, or a family member who can give us a story about how this resonates with them. But in Walking Two Roads, we teach people the most important skill, which is to be able to balance hope with reality. Hope with hoping for the best, planning for just in case, hoping for the best, planning for if things go sideways, hoping for the best, planning for all the what ifs. What if it doesn't work? What if things get worse? This is an episode where we teach people that planning, going down the what if or worst case scenario road, does not dishonor hoping for the best. You can hope for the best and plan for the worst at the exact same time and not become sad, depressed, give up. You can do both. And we explain how. Now, zooming out is where we teach you the skill of asking your clinician what the big picture of your illness is. So for example, if you have Parkinson's, there is a pattern to Parkinson's over time. There are features of early, middle, late, advanced, and terminal Parkinson's. There's an average timeline for people with Parkinson's, and there's lots to know about Parkinson's. And so we invite people to know what the big picture, zooming out and looking at the big average picture of your illness is, instead of just being in the weeds. We want to pull people out of the weeds and look at the forest of their illness. And then the next one is Know Your Style. This is an episode about appreciating who each and every one of us is as individuals. I know how I have been my entire life. If I look myself in the mirror, it ain't all pretty. There are ways I deal with challenges that are just typically Sammy. And I have personality styles and traits that are going to stay true to me for better or for worse. when I am afflicted with an illness at some point in my life. Going back in my own history, when my parents got divorced twice, when my first boyfriend dumped me, when I didn't get a job that I wanted, dealing with challenges in my past can help me understand how I'm likely to walk my road in the future when I have a progressive life-limiting illness. And I know my husband well, and I know how he is very different than I am. And I know how my girls are, my children. And so this episode is about knowing yourself and being able to harness the good coping mechanisms that you have, and also to be aware of some of the pitfalls that you have run into. And to know that you and your crew around you, your family, your friends, whoever that is, we all have different styles and different needs, and we're each going to walk your illness journey differently. And we also go into how you can match up with people, so that, for example, if you're an ostrich and you tend to hide your head in the sand, we're not going to change you. But you need to know what that means when you have an illness. Someone in your crew, like your husband, might be a super seeker, and what that means, and how together you actually are a good pair when it comes to you knowing about your illness and your health. The fourth one is customize your order, and that one is about helping you understand what the usual care looks like, and helping you to figure out if the usual care for an illness matches what you personally value and believe in. And so we also give skills so that you can start nudging and edging and shouldering the healthcare system, so that you make sure that I just say Parkinson's again, that your Parkinson's journey really matches what you value, as opposed to the standard Parkinson's journey. There's 3 more here. Expect the ripple effects is the shining light on the people in your life. That if I have an illness, I'm the star of my illness, but there are best supporting actors and actresses who will have a journey through my Parkinson's, separate and connected to my journey. And so we want to shout out that, a person doesn't go through their illness usually and not affect other people. And the people in your nearest surroundings just happen to end up being your caregiver, with no job description, with no interview, with no idea of what that's going to entail. And so that episode really shines light on the fact that when someone has a progressive life-limiting illness, you come to that illness as a unit with your people, not just the person alone. And then the next one is called Tag Your It. And that means that someone in your inner circle needs to know that they're going to have to be the person, because the healthcare system has gaps and it's not perfectly oiled. And so you need to actually become almost like a project manager of your own illness experience. And if not you know your style. I'm a disaster, I'm disorganized, I'm not a good manager type. Well, then in the Know Your Style episode, you learn that you need to find someone who's going to be your manager in your inner crew and tag their it. We give you skills to how to make sure that as you travel through your illness journey, that you feel like you always have a full chart of your storyline, and you can offer that like a carrier pigeon to different healthcare teams. And then invite yourself is just really saying, folks, if you're going to take a passive backseat role in your health journey, you're at the mercy of whatever people you interact with in the healthcare system, for good or bad. You'll be floating, bobbing in the water, and You'll feel like you've lost control, like many of my patients. You'll feel like you've lost a sense of yourself. You'll feel like your illness experience doesn't match who you are. You'll feel like you lost meaning and hope in your life. Backseat people can stay in the back seat only if we have a couple people in your crew who are willing to take a front seat or the driver's seat. Okay, so there's 2 other episodes after this 7, and the 9th one is one where we describe what the last year of life is like. So all of these 7 are for anyone to use at any point in your illness journey for whatever illness, whether it's curable or not. These are just really good tips. The 9th episode, like I said, is called When Time is Running Out, because so many people wonder what the last year of life looks like. How do I know when I'm in my last year of life? How do I know what to expect in the last year of life? What's normal about the last year of life that I'll notice and that my family will notice? How do I know how quickly or how slowly things are going? And that's what that When Time is Running Out is about. And of course, it's optional whether or not people want to listen to it. And then the 10th episode is just stepping back and pulling all these episodes together and, weaving them back. We've teased them apart in every episode, but then we put them all back together and we digest them and we talk about what it's like to be a new patient and family that has moved from in the dark to an in the know, woke experience. And all of this is really just meant to make sure that people remain in control through their illness journey. And so I just thought I would mention before we open up to questions that on our website, we have other opportunities. We are starting a podcast club if anyone is interested. If anyone is interested in listening to any of the episodes every Thursday starting in May and June, it's like a book club, but it's going to be a podcast club. It's going to be people's opportunity to dive deeper into the different episodes, to share their experiences, ask about skills, learn, share. We've never done this before, so I can't really tell you if it's going to work out or not, but we're very excited because we merely scratched the surface in each of those episodes. And so to join the podcast club, if you're interested, you just go to the website, you put, just like you actually joined this breakfast club this morning, the exact same way, you do it on our website and you listen to a podcast and then you come on the date and discuss or listen. You don't have to participate. And that's it. So.
Samantha, thank you so much for that. That was very profound and very important and presented beautifully. So thank you so much for that. I'm sure there are some questions. We all struggle with these issues, either personally or with people that we know and love. Is there any questions or comments to share with Dr. Winemaker? Dr. Levine?
Yeah, Sam, excellent, wonderful talk. Couple of comments. I think I'm going to be on one of their, Sammy and Jen interviewed me, so it was a lot of fun. And I think what they're doing is a phenomenal work. I actually recruited Sien from Hopkins. He grew up in Oakville, but he was down in the States and brought him back a number of years ago, and he's a dynamo, and he has some really good ideas. I think everything has to be taken in context, and I've been thinking a lot about, Sam and I have spoken a lot lately. I wonder if there should be an 8th, apart from the 7 key, the 8th key, which should be something about on the left side listening, and on the right side hearing, or vice versa. Because one of the issues is, it's true, it's very true, and I'm trying not to be defensive, that the medical system is very often tuned out to many of the issues that Sam has brought up. But also there's the issue is so is the patient and family come to see a physician, and they're told that, well, you have advanced cancer and you have 6 months to live, but we're going to try something, this X, Y, and Z. And even though the patient has been and family have been told what the prognosis is, that half the time they actually leave the interview and they think they've got a curable cancer. It's hard to believe, but that's what they want to hear. And also, you know, we tend to make it as, you know, put a little sugar on it and stuff. But I do think there is the issue of the context of what's happening at the time, and people don't want to hear bad news. There are techniques, obviously, that people should be taught on both sides, but I do wonder whether that's something that needs more discussion in what you and Sienna are doing. The other thing that is problematic is we're in a consumer-driven, advocacy-driven society, and when people come for care, they want to be cured, even though if they're told well, we can't cure you, they'll say, well, refer me to the Princess Margaret, et cetera, et cetera, et cetera. So I do think there should be there's opportunity for more work in the 7 keys. And that's what you and Sienna are doing. I mean, I think it's going to be a lifelong project, labor of love, but it's brilliant work, and it's not easy work. So Sam and I have shared many patients over the years, and I can tell you, many of them have come to Sam at the last minute, not, you know, exhibiting all the things that Sam said, that they, you know, why didn't they know more? So, etc. So it's a very important area that needs a lot of attention. So kol hakavod to you and Sien.
Thank you. Thank you, Mark. Yeah, so I didn't know if you wanted me to mention that I saw your name there. So we had an opportunity, Sienna and I, to interview Mark for over an hour, you know, listening to Mark reflect on an amazing decades of his career as an oncologist and researcher. And it's just really interesting to hear him look back on his practice and reflect. So thank you so much for that, because we are planning on, I always laugh when I say dropping because it's so cool and I'm so not cool. We're dropping more episodes. That's what you say, but anyway, dropping. And yeah, we're going to have one that focuses on Mark and his career. We also interviewed medical students, and we're interviewing all sorts of other people that have different perspectives on this content. And so thank you, Mark. I appreciate your comments today as well. And yeah, you know, we have considered that so often about this idea of people, like, is it really that healthcare providers aren't offering the information, or is it that patients and families don't hear? And I think it's probably both. And so you're right. So we've got a problem probably on both sides that needs to be addressed. And then in terms of people wanting to go for more and more treatments, that's more likely to happen when people aren't given the opportunity to shift their focus of hope. Hope has the ability to change over time from the beginning of an illness to the end, as long as a person understands the reality of their illness. And if people are still expecting to be cured or expecting to live forever, then they're going to hope only for treatments. But if someone can gently begin to understand that they're moving through stages of their illness, they can begin to shift their hope to other things, like hope for more time, then hope for good symptom control, then hope to be able to be cared at home, then hope that their family is strong through this, hope that they're not a burden, hope that they'll die peacefully, hope that they'll go to heaven, hope that their daughter gets married one day. So hope is able to move along with an illness as long as it's calibrated with reality of where the person's at in their illness. When we don't talk about the real stuff, hope gets stuck, and people then end up hoping for unrealistic things. There is something in the chat. I'll just say someone's asked about anticipatory grief, if there's any podcast. I'm sure there is. I have to admit to you, I have never listened to a podcast. I have no social media. This is so, I look way more cool than I really am. So I don't know, but all I do know is that anticipatory grief is a really important construct. For the people who don't know what that is, again, I go back to the value of having time. When you don't die from something sudden, and instead you have a progressive life-limiting illness, you as the patient and your family, especially when they understand the illness the whole way through, start grieving while they're still hoping, while they're still having a blast, while they're still enjoying life and having good quality of life. But people begin to ready themselves for the middle, the advanced, and the terminal stage of illness. That's called anticipatory grief. When you begin to know and acknowledge that you are going to have a loss at some point in the future. And you begin to grieve before the person's even gone. And it's protective. And it so that when someone does go, it stings a lot, but you've done so much of your grieving that after the acute events, people surprise themselves that they can actually pick up and get back to work and rejoin the Breakfast Club and, you know, move on. And so if you don't have the opportunity to be woke and in the know throughout your illness, then when a person dies, it feels like a car accident. And grief starts at that moment and feels more like a shocking death. And then you have to do all the work after the person's gone. So this idea of being more aware of what your illness journey is going to look like allows people to begin down the journey of anticipatory grief, which is really important.
Thank you.
I'd
Jill?
like to say something, could I?
Yes.
Go ahead.
We actually met once. It must have been just after you came to Hamilton, and my husband was in hospital, and it was just after you came, and you came to see him, and I can't remember if I had my little dog with me or we were talking about him, and his name was Farfel, and you said, "Oh, you must be Jewish." So I got a dog named Farfel, but that's beside the point. My husband was sick for about, I don't know, 37 years of our married life, and he had every single kind of thing that you could have, and I have to pick up on what you said about hope. He wanted to know everything about everything in depth, and the medical community, and we saw a lot of different kinds of specialists, were very, very good. And you said that Mark said before, I think the medical community needs to learn a bit more. We didn't experience that. They were very, very good at explaining and what might happen, what might not happen, and so forth. And his attitude then was, well, hope, and I'll do the best I can, and I've learned what it's all about, and I hope that what they told me was correct or not correct, and so forth. But I think that the medical profession telling him everything was most helpful. Mm-hmm. I'm not sure I was always with him, but I'm not sure that I wanted to know everything myself,
Mhm.
but I was always there to support him. And I have to say that the support of the family was so important over those 38, 37 years. And you alluded to that as well, that you have to have people around you that you know care and support you. So we went through the grief process because he had so many things over the years, like major cancers, heart, everything. And I think we were all ready and he was ready. And I think all that process was very helpful.
Mhm.
So I
You know,
can say,
thank you for sharing that. When you said farfel,
yes,
doing
you
suddenly
remember?
I had a recollection of farfel.
I don't remember if I had, it would have been a pup then, whether I had him with or stuck it, hid him inside. He was only a little one.
But you reminded me, thank you, Sheila, of something really important I forgot to say, that everything that I said and everything in the podcast is really just to invite people to know that there's more to know. It's not meant to force people to know. And it's not wrong if you decide, no, thank you, I don't want to know anymore. No, thank you, I don't want to know my prognosis and my timeline. That's fine. But we felt strongly that patients and families need to know there's a whole pile of information that you could know if you want it, and the benefits of knowing, but still honoring that many people will not want to know bits and pieces. And that's fine too. But those people also have to understand, how does that bode for you going through a journey with blinders on? Again, we're not going to change people. We're not wanting to change people. We're just wanting to tell people, guys, there are opportunities to be more in control in your illness journey. You can't change the illness, but we can change how the illness feels. So it's just about an invitation. So it's okay, Sheila, that you maybe didn't want to know because your husband wanted to know and he had all the information. And that's also an important point. Just someone has to know a little bit more. Someone has to be more curious, and someone has to be willing to look at more of the long view. Then everyone else can put their heads, not that your head was in the sand, but everyone else can live day to day. There is another comment. Do you speak to cultural differences and obstacles that may silence the communication with patients whose family members want to protect them? Yeah. So so cultural differences. So it is true. We don't go into that in the podcast, but that's definitely an opportunity for yet again another something down the road, but hugely important. And again, we want to honor every person's culture and the way a particular culture's vibe is, the way they deal with information sharing. But we also have to make sure we don't assume that every person in a culture ascribes to the same thing.
That's right.
And so it's really, again, important for us to invite people to know more and allow every person to tell us how do you walk this journey as someone of this particular culture, and how do you as a person want information? How much? What's customary in your life? Do you normally ask your son to be the one that we're going to be speaking to, or do you want to have the information? And it's really about clarifying with every individual about the cultural overlays and then personally what they want. And then honoring whatever they say. People can say, I'm of sound mind and I'm of this culture, and in my culture and for me, I don't want you telling me anything. You go to my daughter. I don't care if you, in your healthcare system, you say that I have to know. I don't want to know. And so we say, okay, pros and cons. And if you don't want to know, we'll go to your daughter. We just needed to invite you.
Any other questions or comments?
I was just wondering, Dr. Winemaker, if for you personally during the pandemic, has it been more difficult ministering to patients during this particular time? Because it's hard enough for those of us who are healthy to live our best lives, let alone to have to deliver news and receive news at this point in time.
Yeah, thank you. That's a really important and amazing question. You know, yeah, so I mean, I could answer that from my perspective, like being the doctor, how has it changed for me during COVID and the pandemic, and how it's changed for the patients and families that I care for. And, you know, I could go on and on forever, but I won't. I'll just tell you a couple of things. That in order to protect the healthcare providers, many of us had to move to virtual like this, virtual practice. And I actually just wrote a piece on what it's been like to be a doctor working virtually. I'll share it with the rabbi and he can circulate it to you guys. But the bottom line is I miss my patients. I miss them so much, and the families. I went into community home-based care because because of the colors, the sounds, because I can care for people in their own environment and see how they are in their own environment, what their house is like, what the pathway and the lawn is like moving up to the door, what's on the porch, who answers the door, are they in pajamas, where's the patient in a hospital bed in the dining room, and what's all the nonverbal stuff going on behind the patient. I can't see that virtually. And so I feel like I, in a way, have been stripped of some of the senses I didn't realize I was using so much on a home visit. And so this is so one-dimensional, and I miss my patients, and I don't think the quality of care is the same, and the relationship isn't the same. And for either of us, it has its role, and I'm sorting that out, but I can't wait to get back into people's homes. And for patients and families, I will say that it's been really hard being cared for at home. I would say, you know, just briefly, people are scared of going to the doctor because of COVID. They're scared of going to the hospital. They don't want their loved ones in congregate settings like nursing homes or retirement homes or hospices. And those places are discharging people back to people's homes because no one wants to be there. And the hospitals are offloading patients faster and more furious. And the net sum is that there's more people with more serious problems living at home. Yet, we don't train families to be the first responders. We don't tell them what to expect. No one gets a course in how to be caring for their loved ones at home. And the nurses and the home care, the PSWs, have not increased in supply with the demand increasing. We have more people at home, but less people to share amongst for home care. And the PSWs and nurses are people too. They're scared of going into people's homes. And the families and patients are scared of having different people coming into their homes. And the result is that we have a lot of crises going on at home. I honestly cannot believe what we put on the shoulders of families. And I know that, you know, there's something like 80% of people when surveyed would rather be cared for at home and die at home. And I understand that, but I also understand that people don't fully understand what it is like to be at home and what are the limitations to being at home. So yeah, thank you for that question. I don't know if does that answer your question? It's hard. It's really hard.
Yes, thank you very much.
Yeah.
There's one more question from Ginny Levine in the chat box about how you ensure you don't suffer burnout with this kind of highly emotionally charged work.
Yeah, I mean, if I was to be perfectly honest, I would say, you know, probably at times I do feel a little bit burnt out, but most of my burnout comes from advocacy. It's the politics of it. It's the systems issues. It's feeling like you're educating people and getting nowhere, knocking your head against the wall. But my clinical work is my joy. I absolutely feel that I get more from my patients and families than I give. 2 days ago, I saw a patient, and at the end of the visit, I said to the resident that I was working with, you know, that person has made my day. Like, here I am in my beautiful home, you know, oh, woe is me sometimes. And this person has so many things going against them. And she was so positive, wanting to live. She wants, she's so brave. She was so sweet. And I don't know, and Mark Levine will tell you this, also, like, our patients and families often put the wind beneath our wings. The clinical work does not, dealing with death and dying does not burn me out. For me, it's part of life. I accept it. I know I'm not going to die, but everyone else is. And so, and so I know what I'm in for. I know when I meet patients and families, what's going to happen. So that part, I feel like I can be helpful. And I am helpful, and that feels so good. But it's the other stuff that burns me out. So doing things like this podcast or being able to speak to you guys today, that protects me from being burnt out, because like, I feel like, oh, I'm not just sitting with one person. Look at all these people. I have 20 more people who are now in the know. And this kind of stuff excites me. Oh, plus Pinot Grigio. Pinot Grigio.
Have to know the cantor's howling in the background. Dr. Winemaker, Samantha, I want to deeply, deeply thank you for being with us this morning. The words and the ideas that you shared are both profound and beautiful. It's in Jewish tradition, we refer to somebody who was in the process of dying as a gosses. There's actually a term for it. And while we have an obligation to care for the gosses and also to recognize very deeply that this is a living person, this is not a dead person, it is considered an honor to be in the presence of a gosses, an honor to be able to care for them, because they are going through something that we can probably never understand until it is our time, and yet we have a chance to be there with them and to tend to them, and that is considered amongst the most holy work one can do. So what you are doing is not only important work, it is holy work, and for that we express our gratitude and appreciation to you.
Wow.
So thank you very much for being with you. I wish you all your best to your lovely family. And I want to thank everybody for being with us for this wonderful presentation this morning. And again, we continue next week at 11 o'clock here on Zoom. You can use the same login details, and Cantor Paula Baruch will be talking about her spiritual journey and her call to Judaism and the Cantorate. So again, thank you all. And don't forget, 2 o'clock this afternoon is our wonderful Yom Ha'atzmaut concert right here on Zoom as well. Have a wonderful day, everyone. Thank you so much.
Thank you.
Virtual hugs. Bye.
Virtual hugs. Bye-bye, everyone.
Thank you.